Okay, welcome to the upper extremity. Today we're going to be looking at shoulder radiography. So when should we request imaging or x-rays, in particular radiographs? So as you see here, trauma, particularly with fractures, suspected fractures, some of the tendon issues that are not healing well, labrum tears, any type of rotator cuff tear or impingement, and particularly with recurrent instability. These are all indicated for radiography. And then, of course, shoulder OA is probably the primary imaging modality will be radiograph. You see some other things here: trauma, neoplasms, and metabolic diseases, infections. Those are things that are less common, but obviously need to be imaged if there's some indications for that. So our standard views of the shoulder is the AP external rotation, AP for internal rotation, and AP in neutral, the Y or outlet view, an axillary view, and a acromioclavicular projection. So I'd encourage you to go back to your textbook and for the McInnes book and really look at pictures and be familiar with these setups for imaging of the shoulder area. So the first one is an AP view with external rotation of the humerus. And so what we're really looking for is any fractures of the humeral neck, any bony lesions. This gives a good view of the distal clavicle and a pretty good view of the scapula, particularly the lateral portions of the scapula. It can also indicate any type of inferior dislocation, and in some cases a Bankart lesion will be obvious with this view. So here with the arm at the side, like I say, you can see the acromion here, you can see the distal clavicle, you can actually see the coracoid process. You know the glenoid is here, where the humeral head is sitting here. Got the humeral head, you can see the greater tuberosity up here. The lesser tuberosity is kind of in the middle, so sometimes a little hidden depending on the exposure. So the big thing you're looking for, you can know that it's an external rotation if you don't see the lesser tubercle down here. It's more in the middle, and the greater tubercle is at the very top up here. That's indicating that this view is an external rotation view. The other view is an AP and internal rotation of the humerus. So here you're looking same thing, fractures of the humeral head or neck, any bony lesions. You can see the distal clavicle, you can see the scapula, and the inferior dislocation and Hill-Sachs lesions with this one. So as you see, the X-ray beam is directly into the shoulder with the humerus in internal rotation. And with this view, you see the big one is you see the lesser tubercle here and the greater tubercle out here. So you see you can tell it's internal rotation because you can get a good view of the lesser tubercle here with the glenoid. The coracoid is here. You see the distal clavicle area, the AC joint and acromion are all here. So get a good idea of what's going on bony-wise here. So here's a comparison view of, you can see the external rotation here, the internal rotation here, using the lesser tuberosity or tubercle as the indicator here. If we look at the shoulder AP view in neutral, you can see, like I say, the same thing, looking more fractures, the humeral head or neck, bony lesions, distal clavicle, scapula. An anterior dislocation can be seen in this view quite well, although it may be subtle in its appearance, and the bony Bankart lesion can be seen in this view. So the axillary projection, the X-ray beam is projected through the axilla, and the film is up here at the top. So you can see this view here. This shows the relationship of the glenoid and humeral head, which is a really good view for looking at dislocations. and possible fractures of the proximal humerus. So you can see the view here. Sometimes they'll, in some cases, put the film down at the bottom and shoot it through this angle here, about at a 5 to 10 degree angle, to get a view, to get the same type of view here. But you can really see the relationship of the humeral head to the glenoid. You see your coracoid process out here. You see your tuberosities here, and then you see your acromion coming around back here. So you can kind of get a good view of what's going on with the relationship of the glenoid and humeral head in this view. So if you are suspecting a dislocation, this is the view additional view you'd probably want. The Y or outlet view of the scapula. Here you're really looking for this coracomial arch, any type of acromion pathology, bone spurs type stuff, and then you're also able to see the space for the rotator cuff as it goes out to the humerus. So here you see the view. The beam is shot across the towards the back and through with an angle here, and the film is placed right here, film cartridge. So you're turned at about 60 degree angle to get this view for these scapula. So here we see the beam through the supraspinatus fossa. You see this nice open space, outlet space here for the rotator cuff, and you see the acromion up here, the AC joint. So you can see some really good view here of what the space here looks like. If you're suspecting like impingement or some sort of acromial hooking, this is the view you would see that on. So here's another view, and we can look at the different types. There's type 1, type 2 hook, and the type 3 hook, and you can see the amount of space here that's allowed based on the morphology of the acromion. So usually they look at this measurement here versus here, and then your a more narrow view here with type 3. So you can see that the O to A space here is less than the O to C space here. So that tells you that there's a type 3 hook. And if you look at the O to A here is greater than the O to C, that's a type 2 acromion. So in here you see A, B, C all lined up together in a perpendicular angle here. So it tells you that there's no hook on this acromion. The acromioclavicular view. So here we're looking at the AC joint. So we're looking at the relationship of the acromion and clavicle. You can also see some clavicle fractures possibly. So it allows you to kind of get a good view of what's going on with this AC joint. So if you suspect AC pathology, those shoulder separations or AC joint sprains, any type of arthritis at the AC joint, you may want to get one of these views. And here you can see the beam shot up at about a 15 degree angle up through the shoulder joint with the film behind the patient here. So if we look at the AC joint sprains here, you can add weights, having the patient wrap weights around the wrists so that you don't activate the rotator cuff reflex by gripping. They tie a rope onto the wrist and add weights, usually a few kilos, and look at the joint space changes. So this should be within 0.3 to 0.8 centimeters, or really 3 to 8 millimeter separation, no more than that. And you should have about a 1 to 1.3 centimeter difference here in this space, in the coracoid space. So that's the parameters we're looking at to determine if there is a sprain in this joint. So as we look at doing a bilateral comparison here. So you see the right shoulder, nice space here, little space here, so it's all fairly normal here. Then you add the weights here, and you see a big separation here for the AC joint. So this would be a grade 3 separation of the AC joint here. See a huge space between the corticoclavicular space and between the acromioclavicular space here as well. So these are all good views of normal separation here. And then you can look at an AP view of the scapula. So it's more focused on the scapula, so we want to make sure that scapula is in the picture here. Here it's gotten cut off down here at the inferior angle a little bit, but really looking for fractures here is a little more difficult to see for these type of individuals because you have other structures in the way. So here you're going to put the shoulder kind of in a 90-90 position here. 90 degrees external rotation, 90 degrees abduction. Shoot the chest, the X-ray beam with the plate underneath the patient here. So you really have to look closely at the scapula here to see if there's any types of fractures or pathology in the scapula. Here you can see a lateral view. So we turn the patient, shoot the beam along the plane of the scapula with the plate underneath the patient here. So really you're looking for any type of fractures or tumors, those type of things along the scapula. And so you can see the scapular plane here, and there's the border of the ribs. So you can kind of see how the scapula sits here on this angle here. All right, that concludes the shoulder basic views. So next we'll move on to the elbow.